blood pressure is measured. Any pressure is measured with the help of a manometer. Blood pressure is measured with the help of a sphygmomanometer. Sphygmomanometer was initially devised by a doctor by name Riva Roxy. In fact, the cuff, that is C-U-F-F, not C-O-U-G-H, the cuff that is applied to the arm while measuring a blood pressure is often called the Riva Roxy cuff. Though the entire instrument was devised by Riva Roxy, it was improved upon by Van Rastlinghausen. Improvement in the instrument. Nowadays you find digital instruments are available of different types, but I find that in hospitals, doctors still rely upon the sphygmomanometer as a means of identifying blood pressure. What causes this hypertension? High blood pressure, which we said is generally measured in terms of diastolic blood pressure rather than the systolic. Normal diastolic blood pressure is 80 millimeters of mercury. In hypertension you find, or high blood pressure, the pressure rises to about 90 and still above. For aged persons you find 90 is considered to be more or less stable. The persistent high blood pressure puts a great load on the heart. Most of the high blood pressure is because of certain reasons. One of the reasons is viscosity of blood. Viscosity is a ratio of RBC is to solutes of the plasma. A rise in viscosity means a rise in RBC count, a lowering of the water volume of the plasma can make the blood more dense and make it more difficult to move about within the blood vessel. A second is peripheral vascular resistance. Generally written as PVR. Peripheral vascular resistance depends on a sort of impediment, a sort of hurdle created within the blood vessels in the peripheral circulation. The hurdle can be arteriosclerosis. Arteriosclerosis is a hardening of the blood vessel, making it stiff, less elastic, so that the blood vessel does not respond to the flow of the blood and remains absolutely stiff. Arteriosclerosis comes due to a natural process of aging, which artery must suffer arteriosclerosis, which shouldn't suffer arteriosclerosis, is not exactly a point of discussion in biology. Apart from arteriosclerosis, there could be a reduction in the luminar size of the blood vessels by plug-like formations. That is called atherosclerosis. Atherosclerosis, arteriosclerosis are two closely related but different types of conditions of the blood vessels, which can bring about a reduced flow, greater peripheral vascular resistance, making it difficult for the heart to pump blood into the systemic blood. If these are reasons for hypertension, the causes which lies behind what causes hypertension. Well, one is family history, I would say genetic causes, though you cannot draw a pedigree analysis by writing out persons suffering from hypertension in the family and then coming down to some reason. Hereditary factors do appear to play, but do not expect Mendelian type of inheritance of high blood pressure. If both parents have high blood pressure, it is likely that the children may have high blood pressure, not necessarily, because there are other reasons behind it. What are the other reasons? Well, it depends on what type of blood pressure you are talking about. Well, one for which we do not or cannot find out the reason, a person just becomes an individual with hyper blood pressure, hypertension. That is called primary hypertension, for which a reason cannot be identified. We call that primary or idiopathic. One of the causes assigned to primary or idiopathic hypertension is genetic, as I wrote out just now. The second is something connected with the diet, excessive salt intake. Excessive salt will remain in the plasma, converting that into a hypertonic solution. So this could cause a series of reactions, one behind the other. Lack of sufficient fruits, vegetables in the diet. This also is said to create hypertension. Number 3 is something that we already know about. Excess amount of fat under the skin, obesity. Obesity has never been clearly defined, but suggestive ideas are there. Say about 30% more fat than in the normal. That is obesity. Obesity certainly puts a load on the heart, and one of the reasons for causing idiopathic hypertension. Kidney diseases. Problems with the kidney for which a nephrologist will have to be consulted in the hospital. It can cause hypertension. Recently, a cardiologist told me, he was a student of mine. He said, nowadays we have combined cardiology with the nephrology, sir. It has become cardio-nephrology. The two are so intimately connected, he says, that one can affect the other in its functioning and in its deformities, disorders, whatever it is. So, kidney diseases can be the cause of hypertension. Hypertension can cause kidney diseases. Hypertension can also, persistent long-term hypertension certainly leads to damage to the cornea of the eye. A person who suffered hypertension for 20 or more years once visited an ophthalmologist, one who deals with the normal and diseased eyes. After looking at the state of the eyes, the ophthalmologist shouted at the patient, "What were you doing all these years? The pressure within your eye has gone up, and you are in for glaucoma. Should have come to me earlier. I was merely trying to establish a relationship between hypertension, kidney disease, and ophthalmic problems. It is left to the departmental doctors concerned to advise you as to what exactly is the cause and what could be the relief for that." Hypertension can also be secondary, which means it appears after the primary hypertension has been in vogue for some time. That is because of many hormonal causes, that is endocrine disorders, kidney disorders, plus nervous disorders. All the three contribute to secondary hypertension. Now, primary and secondary hypertensions, when persistent for a long time, can cause problems. So we said, blood pressure can be measured. What else can be measured? Well, heart rate, HR it is written, number of beats here, cycles, number of cycles per minute, heart rate, generally given as 72 beats per minute. Do not expect the bookish value everywhere. Bookish value says 72. But you find a lot depends on the activity of the person. Physical exercise strenuous, I would say. Strenuous physical exercise tension, long-standing, persistent tension can raise the heart rate to nothing less than 125 to 150 per minute, maybe even higher. There are two instances where we make use of two terms. One is bradycardia, another is tachycardia. Bradycardia is a heart rate which is more than 100 per minute. Tachycardia is a heart rate which is less than 60 per minute. It also indicates that heart rate has not been regulated. Regulation of the heartbeat is ascribed to one part of the nervous system which is called autonomous nervous system, which is not under the control of the will, volition. So bradycardia and tachycardia are conditions of the heart. The heart rate, of course, depends on a number of other factors. Contractilability of the muscles of the heart. A very important thing. Has there been a reduction in the muscle mass? Has there been an increase in the muscle mass? Hypertrophy. The normal. We always speak about the average healthy adult. In an average healthy adult, the heart rate is about 72. Stroke volume. Stroke volume is often written as SV, volume of blood pumped per stroke, per cycle, per beat. Strike is beat, volume, amount of blood pumped per beat. How do we calculate? We calculate the stroke volume based on two values available to us. What is that? Both refer to ventricular volumes. What are they? One is the end diastolic volume, written as EDV. This can be mentioned even in connection with the mechanical events of the heart when you refer to ventricular systole, ventricular diastole. This is end diastolic volume. Amount of blood left in the ventricle after they are full. End diastolic. When the diastole ends, this is given as 135 ml per stroke. The other is end systolic volume. This also can be mentioned in connection with the mechanical event of the heart when you refer to ventricular systole. This is given as about 65 ml. blood remaining in the ventricle even after systole. The difference between the two, 70 ml is the stroke volume. So stroke volume is about 70 ml, the amount of blood pumped at each beat. Amount of blood pumped at each beat. This has something to do with the ejection fraction, written as EF, and identified by one of the radiological techniques called electrocardiography. Electrocardiography. Graph, picture. This gives an idea about the several readings are available on the instrument. Possibly it's related to another instrument called the color Doppler. The readings can suggest a number of things of the working of the heart. You can actually see valves closing and opening. You can actually see blood rushing. On the monitor, colored pictures appear. Ejection fraction in normal, adult, healthy hearts is about 50 to 53. But in a diseased heart which has lost its ability to contract in the normal circumstances, the ejection fraction can come down to about 20 to 25. An ejection fraction of 20 to 25 is creating problems for the person who has it. Most of them result in what is called breathlessness. Anyway, end diastolic and end systolic volumes give us stroke volume. What is the cardiac output? Cardiac output, written generally as CO, don't mistake it for carbon monoxide. Cardiac output is heart rate, HR, into stroke volume, SV. HR is about 72, SV is about 70, so this makes it about 5,000 ml or 5 liters. It is not steady. It depends on the number of factors. The factors that we wrote out in connection with the heart rate. Any reduction or increase in the heart rate will affect the cardiac output. Any reduction or increase in the stroke volume will affect the cardiac output. What we have written is a value for a normal adult healthy heart. I said it is about, not exactly. So it depends on heart rate, stroke volume. It can be understood. What exactly is the pulse? The word pulse is used both in cardiology and in conversational English language. Before you introduce a controversial reform, there may be a question: have you felt the pulse of the people? Which means, do you know how people will react to this proposal? Feeling the pulse. We are not referring to that. We are referring to a cardiological phenomenon. Pulse. Pulse is a pressure wave. Pressure wave passing along an artery. Passing along an artery. Where is the pressure wave created? Of course, due to the beating of the heart. The pressure is generated only there. So a wave of pressure passing along an arterial wall is a pulse. Pulse must be very high in the region where the blood is just escaping from the ventricle. As you come down to the peripheral circulation, you find it is lower. Pulse is generally felt in the wrist region, WRIST, and the artery selected for that is the radial artery. Well, if you know the position of the radial artery, you can always feel the pulse. You can keep a watch nearby, and not a difficult task at all. Not a difficult task at all to feel the pulse. The beating of the artery can be felt there, and the pulse is pulse rate. What is the pulse rate? It is the difference between systolic blood pressure and diastolic blood pressure. Systolic blood pressure 120 millimeters, diastolic blood pressure about 80 milliliters of mercury. This gives you the pulse pressure, PP, about 40 millimeters. Very often, students of biology write out the proportion of the various pressures that they study in the class. Systolic blood pressure is to diastolic blood pressure is the pulse pressure. 3:2:1 they say for a normal, once again, healthy adult heart. If all these do not create heart sounds, the heart is not working. Sound is always produced by vibration. I may ask, vibration of what? Where is the vibration? Heart is all fixed there, how can it vibrate? Well, the entire heart doesn't vibrate. For heaven's sake, it is not the vibration of the heart, vibration created within the heart. What creates vibration within the heart? Two possibilities are there. One possibility is the flow of the blood itself. The flow of water in a stream creates a sound. From a distance you can feel that there is a stream running nearby. Just like that, the blood flowing within the heart can create a sound, but that is so feeble that it cannot be felt. It cannot be investigated by any instrument. What can be investigated? That which can be investigated are those sounds which are produced by the mechanical events of the heart. Which mechanical event? Contraction, relaxation, not of the heart itself, but of the valves. Oh. Which produce the sound? Is it opening of the valves or closing of the valves? Heart sounds are produced by closing of the valves. All sounds produced within the heart, normal sounds I am saying, because abnormal sounds are called murmurs. Heart murmurs. They might indicate a diseased heart. Doctor knows well why a murmur has been created. Is it due to the ineffective functioning of the valves or not? It is not our concern. So, if the heart sound is produced due to the closing of the valve, which sound is produced during which closing? You find 4 heart sounds are identified. S3 and S4 are created due to blood flow. Feeble. Difficult to detect. S3 and S4. S1 and S2 are the 2 heart sounds which can be heard with the help of an instrument called stethoscope. Stethoscope is merely an amplifying instrument. Please, stethoscope is merely an amplifying instrument. When its head is kept against any part of the body, if there is any sound, it can be heard clearly. It does not measure. It is not an instrument which measures anything quantitatively. Just a sound. It can be used in identifying functions of the lungs also, of the heart as well. A stethoscope identifies 2 heart sounds, S1 and S2. S1 is called the first heart sound. S2 is called the second heart sound. This is generally written as LUBB, lub, and that is written as DUPP. You cannot miss the repetition of the alphabets there, B in the first and P in the second. Longer duration. Sort of feeble, of low amplification, caused due to closing of AV valves. I had already mentioned opening of the valves do not produce any sound, it's only the closing of the valves. Closing of the valves, the vibration caused due to the closing of the valves. No, not snapping shut. Dup. Shorter duration. Higher amplitude caused due to closing of the other set of valves. One is what will semilunar. So both sounds are produced due to ventricular functioning. Both sounds are produced due to ventricular functioning. When ventricles contract, the AV valve shut, ventricles relax, semilunar valve shut. With all this background, we are in for finding out the roots of blood flow, circulatory roots. Circulatory roots. Where does blood leave the heart? In other words, it is just a question of learning, pumping and draining. Well, we can write it as contraction, relaxation. Not exactly that either. Emptying, filling. Emptying and filling of each chamber of the heart. We have already pointed out that the atria contract together, ventricles contract together. We have pointed out something else. When atria are contracting, ventricles are in the relaxed state. I use the expression out of turn. If you remember correctly, out of turn I said, because the two chambers work at different times. So which are the two circulatory routes? One is connected with the right side of the heart and pulmonary circulation. The other is connected with the left side of the heart. Systemic circulation. Pulmonary, reference to the lungs. Systemic is reference to the whole body. Not to be confused with systematic. It is a systemic disease which is likely to spread throughout the body. Example, AIDS is a systemic disease. Something else, malaria is a systemic disease. While some other diseases are localized, they affect only certain parts of the body. We are not referring to that. Systemic. Please use the word whenever you have to make a reference to the entire body. Systemic disease, systemic circulation. Pulmonary circulation is associated with the right half. Receiving and pumping. deoxygenated blood. Shall I write venous blood? For your sake, I'll also write impure blood. That is the expression you have been learning from the lower standards, but it's time to give it up. You may refer to it as venous blood or deoxygenated blood. The whole thing starts with the right atrium. Right atrium receives venous blood from two sources. If you remember correctly, superior vena cava, inferior vena cava. Both drain it into the right atrium. There is another draining it into, that is a coronary sinus. We shall refer to it later under systemic circulation. So, right atrium to right ventricle, right ventricle through pulmonary artery, to the lungs, oxygenation in the lungs, back to the heart, but not the right atrium. Back to heart is left atrium. By the pulmonary veins. Just supply and drain from the lungs a very short route. Why do you say short route? Because the lungs are very near the heart. The blood vessel length and diameter are very short. It has nothing to do with the rest of the body, nothing to connect it with the systemic circulation. So this is lesser circulation. Here, lesser means shorter. Covering a shorter distance nearby. The other is systemic circulation. This is associated with the left side of the heart. Left side you find, left side of the heart, receiving and pumping. Oxygenated blood. To all the parts of the body. It starts with left atrium connected to pulmonary veins. Pulmonary veins, as you know, are generally exceptions because they carry oxygenated blood from the lungs. Lungs nearby, 4 of them are there, 2 from each lung, entering into the left atrium directly by 4 different openings. So, LA to LV, left ventricle. From the left ventricle you find what takes its origin? Aorta. From the aorta to through its branches to all the parts of the body. Branching out. Aorta has a large number of branches. Do you mean to say the superior vena cava and inferior vena cava do not have, they have branches? They are formed due to the joining of the branches. There is a major difference between the artery and the vein. Artery branches out. Veins are formed due to the union of branches. Capillaries intervene between the two. So, left side of the heart is concerned with the systemic circulation, and a part of the systemic circulation is one that is called coronary circulation. Corona is a kirita in Kannada, crown. Corona is a crown. Coronary circulation involves supply and drainage of blood to the myocardium. Myocardium is a familiar name to you because when we referred to wall of the heart, we said there are several membranes enveloping the heart. One is the fibrous pericardium, the other is the serous pericardium. So fibrous pericardium attaches the heart to the nearby organs. Serous pericardium is made up of two layers, visceral pericardium and parietal pericardium, in between which you find there is a small amount of pericardial fluid, isn't it? To prevent the friction when the heart is contracting and relaxing. You may ask, why should the heart be supplied with blood when it contains the blood itself? The contained blood doesn't flow inside the muscles of the heart. Muscles of the heart, as you remember, compose the myocardium, middle layer. Goes on, responsible for beating. The beat starts when the fetus is about 8 weeks old, mind you. Just about 8 weeks old. And per day the heart beats nearly 1,00,000 of times. 1,00,000 times a day it beats. If the beating is to be regular, all the tissues of the heart will have to be supplied with oxygen and nutrients. This applies to any tissue. You take any tissue, the functioning will depend on supply of nutrients and oxygen. Non-supply of oxygen is anoxia. We are talking about supply to the myocardium. Myocardium is made up of striated muscle cells. Muscle cells are uninucleate. They are not voluntary. They can be stimulated to contract by the electrical activity of the SAN. If the contraction and relaxation are to proceed rhythmically, myocardium is an excitable cell. Myocardium is composed of excitable cells, and the excitation can spread. Excitation can be generated automatically in one part of the heart. It can spread to other parts of the heart. We have seen the electrical activity. How depolarization and repolarization can create waves which can be recorded by an ECG. So, blood supply, well, if this were to be the heart, this is the aorta. From the aorta, fine. I had drawn this earlier, I think. Right coronary artery, left coronary artery, circumflex artery. All these are involved in supplying blood. Running parallel with it are coronary sinuses, but the coronary sinuses open into the right atrium rather than into some other chamber. So coronary circulation is of prime importance. Any problem with the coronary circulation will result in problems of the working of the heart. So some problems with the coronary circulation can create one of them is called coronary thrombosis. Thrombus, as you know, is a clot. But a clot has to be formed only outside the blood vessel, not inside. Outside the blood vessel, it must be formed, it must seal the injury to the blood vessel. We have heard, we have seen what biochemical processes are involved, what are the factors responsible for that. Supposing a clot were to be formed inside the coronary artery, it is a thrombus inside the coronary artery, coronary thrombosis. Blood is flowing. The free clot is there. Thrombus is an attached clot. Embolus, E-M-B-O-L-U-S, the free clot, which moves along with the blood components, blood cells. How big it is, we don't know. Where is it going to settle itself, we don't know. But settling and blocking a vital part of the circulation of the heart is certainly going to be a problem to the working of the heart. Coronary thrombosis, cardiologists point out, is one of the reasons for the heart attack. So coronary circulation is very, very crucial, very important. Not that the others are less important. This is kept on a pedestal, highest. Because the heart is a vital organ. If the blood is cut off to the skin, it may not be a problem. But if it is cut off to the liver, it will be a problem. Cut off to the kidneys, it will be a problem. Cut off to the lungs, it will be a problem. Cut off to the brain, it will be a problem. Any one of these circulatory paths may be blocked by a thrombus. Here, since we are dealing with the heart, we are referring to coronary thrombosis only. Now, let us study after this some problems with the heart. Some problems with the heart. We have already studied what is hypertension. Hypertension, high blood pressure. As students of biology, you please do not use the word high blood pressure. Instead, you say hypertension. When somebody tells you, oh, my reading has been 150 by 100, say you are hypertensive. Don't say you have high blood pressure. So, but both mean the same thing. Though both mean the same thing. We have identified two types, primary and secondary. We needn't go back to it once again. Let us take up another heart problem which is called angina pectoris. Angina is a vessel, chest. Angina pectoris is a symptom of a problem. It is not the problem itself, the symptom of a problem. Angina pectoris, otherwise called chest tightness, chest pain. Not ordinary chest pain. It's a crushing pain which starts in the region where you expect the heart, on the left side of the chest, crushing. Person also starts sweating. The pain is so much that it becomes intolerable. It doesn't remain there in the heart anymore, it just spreads to the left side of the heart, left arm. It also spreads to the left jaw of the heart. It is a symptom that the heart is not functioning properly. Maybe the symptom of the heart attack. Angina pectoris could be a symptom of the heart attack. There could be angina pectoris when a person is just resting and may not be very serious. He is not even aware that it is there, but angina may manifest itself more seriously when a person is exercising, walking very fast. Well, there is a difference. The more serious angina could lead to a heart failure or could lead to an actual heart attack and then to the failure. Angina pectoris. Heart attack, heart failure. This is often called an ischemic heart disease or coronary heart disease. I'll write here ischemic heart disease. Ischemia is a condition of non-supply of nutrients and oxygen to an organ. Why did you say organ? Well, any organ can suffer ischemia. Ischemic heart disease, where you find nutrients and oxygen supply are cut off to myocardium. So myocardium becomes hypoxic or anoxic, doesn't hypoxic, lower amount of oxygen delivery. Anoxic, no oxygen delivery at all, and nutrient, when oxygen delivery has been cut off, it means that nutrient delivery has been indirectly cut off, because it is the blood that is supplying both. If it is to the myocardium, you find myocardium will react to hypoxia, anoxia or deficient nutrient supply by a condition called ischemia. Ischemia can lead to a condition called infarct. Infarct is localized death. Localized death of a tissue because it does not receive these two. Infarct. An infarcted tissue is dead and replaced by fibrous tissue. If the myocardium were to be replaced by the fibrous tissue, you can guess there would not be any contraction at all, depending on where this has happened. It could happen in any place in the heart. Why does ischemia occur? Why does it lead to infarct? Myocardial infarct. Myocardial infarct is actually MI, which is as good as saying heart attack. Myocardial infarct is as good as saying heart attack. It will be accompanied by angina pectoris. Symptom: a crushing pain starting in the left side of the heart. What could be the reasons for non-supply of oxygen and nutrients to the heart muscle? You can guess two reasons. One reason is the aging changes. Arteriosclerosis. Sclera, something that is hard, non-malleable. Artery. An artery which has become hard. An artery which does not respond to the flow of blood, expanding or relaxing. Arteriosclerosis, hardening of the artery, generally is a condition accompanying aging of a person. I mentioned it then itself. Which artery must be exhibiting arteriosclerosis or not is best known to cardiologists. Well, the second I pointed out is atherosclerosis. Blocking practically or partial blocking of a blood vessel by a deposit. A couple of years ago, the magazine Scientific American, you might read that, you might be getting it in the library. It's an asset to any library. Scientific American, just like New Scientist, just like Science. Scientific American published a supplement. I was trying to find out where I kept it. I didn't have it, and I see that. I'll show it to you. The issue was devoted to the second aspect of what is that? Atherosclerosis. Atheros is a porridge. If this is the diameter of the blood vessel, you find something gets deposited there and blocks the passage, free flow of blood. Well, a big component of what is deposited there is said to be cholesterol. So possibly obesity might contribute to atherosclerosis long-standing. So ischemic heart disease, also called coronary heart disease. This is heart failure caused due to non-supply of this, first starting with ischemia and then ending up with the infarct. This is very often also called congestive heart failure. CHF, indicating of the congestion within the ventricle of the heart, particularly left ventricle. Congestion is thinning out of the wall of the ventricle and inability to contract, a fall in the volume. What did we write there? Ejection fraction. A fall in the ejection fraction because of the inability of the left ventricle to pump the usual amounts of blood through the systemic circulation. congestive heart failure. When the left ventricle is unable to go beyond its powers, you find the heart fails, and that is congestive heart failure caused due to congestion, overloading of blood in the left ventricle. I think we have covered a number of problems associated with this. It is better that we know what is, some are the techniques. One is you have already studied, electrocardiography. EKG it is called. Angiography, which gives you a complete picture of the blood supply to the heart. Angiography, a graph representing the state of the blood vessels to the heart. And if a doctor is worried about the lack of oxygen and nutrient supply, that is, it may lead to ischemia and infarct, he may perform an angioplasty in which he introduces structures called stents to widen up the blocked arteries. Now, whether it is electrocardiogram, ECG, or electrocardiography, EKG, all these are mostly radiological techniques based on X-rays. I'm sorry I wrote electro here, I should have written something else. Echo. I'm very sorry. Echocardiography, not ECO, as echoing the sound. An instrument which produces ultrasound sonic waves is placed and run over the region where a technician wants to detect problems, and the sounds come back into the monitor of a computer, big monitor, where you find all pictures of the heart come to view. So that is echocardiography. Very often the K is in Greek, cardia, which means heart. Cardio, cardia is in Latin, this is in Greek. So that is the only difference between the two. So with this, we have covered this chapter, and we proceed to the next excretory products and their elimination.